Hi, everybody. How are you? Hope you're doing fine. Here we are with Marshall Dial, Dr. Susan Jacobs. It's a great pleasure to be here with you. How are you?
Great, Ivo.
Very well too, Ivo. Thanks for the invitation.
It's an honor to have you, Doctor. From far away, I'm very late out there. So sorry for the timing, but it's so nice, to be in touch with different continents, different realities. But in either case, we're here trying to teach our colleagues about irrigation aspiration, right?
Right. I'm sure we're going to have a great time doing this.
Thank you. So Marshall.
All right, I'll start us off. So good afternoon, good evening to everybody, wherever you are watching us. We're so excited to have you. This is episode 4 of Stop at Nothing, the live virtual cataract surgery webinar series designed to help young ophthalmologists who may be a little bit isolated, struggling during these difficult times with COVID. In many countries, elective surgery has come, if not to a complete stop, is definitely minimized. So our goal here is to offer you a unique learning opportunity for cataract surgery. Unlike traditional webinars, which are largely didactic and have surgical videos, what you're going to see today will be slowed down, designed for you, so that we're going to look at an individual step, today being irrigation and aspiration, and we're going to deconstruct that step of cataract surgery using unique virtual reality technology to demonstrate how to do this particular step. So with that, I'm going to hand you off to Dr. Ivo and Dr. Suzanne, and we'll begin the session. Thank you.
Okay, so first of all, the important thing is to talk about the importance of what we're doing, right? Let's see if we can, there you go. So irrigation aspiration, it's a moment when we already have, the nucleus out, we're more relaxed, confidence levels are rising, and then we need to, to do this surgical step and master it. Slide 2. And I think you need to be in the correct mindset in this moment. There can be a lot of risk, as you can see there. Why is risky? Well, because you're not that focused in what's happening, and maybe the overconfidence can be bad. I think the important thing is to have an efficient irrigation aspiration. It's to understand what's going on, what are the physics behind it. And, yes, and Dr. Susan, we're gonna have a slide for you right here. Let's see if people can see it right there. And, okay, so we have some technical issues, sorry. The important thing here is the importance of this step, okay? So it's an important step, high risk. You need to understand everything that's happening, and also you need to understand what can go wrong. There you go. Dr. Susan Jacobson, it's an honor to have you here.
Thank you. Thank you so much, Ivo. Yeah, I absolutely agree with you that IA is a time when you've just got over that nucleus removal and you're feeling reasonably comfortable with yourself and you think you're about to finish the case and go home. But that's when things can go wrong, when you let your guard down. And you have to remember basically that you still have to be very careful. Because sometimes you're going to be working with high fluidics. Sometimes you have to know when to go slow. You have to know the exact contour of the bag, because now you don't have much there to protect the bag. You're going to take off that last protective coating from the bag, which was basically the epinuclear shell and the cortex. So what is right down below, excuse me, below you is the capsule, which of course is something that all of us really need to respect a lot. So we definitely have to be careful and not let our guard down, and take it slow and easy, especially when you're a beginner phacosurgeon. So just some of the complications, yeah, I can just go through those points. Some of the complications that you can happen could include a variety of things. Of course, we just talked about PCR. If you go, for example, if your port is facing down, you can have a PCR. If your port is facing to the side and you're aspirating too fast, you could have a Zonla dialysis. You could have an anterior capsular rent if your port is facing up and you've kind of caught onto the capsule and you've given a high shot of vacuum. And other than that, you can do lots of other things, like you can strip off the Descemet's, you could go catch the iris, unknowingly, and that could cause a large dialysis, bleeding, and all kinds of problems. So these are really things that you want to avoid, especially when you're a beginner surgeon. You don't want your confidence to be shattered. So go slow, take it step by step, and understand what you're doing before you do it.
Perfect. And right now we're gonna do a survey here. Oh, sorry. There's one more.
Yes, two more.
Dr. Susan.
Yeah, so basically one thing that you need to know, of course, is your tools. You have two types of options that are available for you. You have the coaxial IA and the bimanual IA, and basically what you pick depends a lot on how you're trained or what you're comfortable with. You could do both. The coaxial is the most commonly used around the world, but bimanual, of course, has its own advantages in that you can kind of get an access to the entire 360 degree of the bag. So the problem with coaxial is the subincisional cortex, and you do have ways of overcoming that with the coaxial as well, by using a 90-degree tip or using a 45-degree tip. But with bimanual, it really makes it much more easier, because you can go and make one more port and then enter with that and aspirate. But one thing you have to remember when you're using a bimanual I&A is that you have to have two ports which are 180 degrees apart. So don't try to put in your bimanual port through the main incision, because it's a very small port and you're going to have leakage through the main port, and that's going to lead to chamber instability and antechamber collapse. So that's something you have to remember. Make small incisions 180 degrees apart, or the other alternative is you continue with your irrigation with the coaxial port and you do just aspiration with the bimanual aspiration probe, and that could still serve you well. So basically these are instruments that you do need to have in your set. Even if you're very used with coaxial, I would still recommend always having a bimanual set in your OR, because sometimes you may get stuck and your coaxial just doesn't work, and at that point of time it's really easy to shift over to bimanual and remove that last bit of stubborn cortex.
Very interesting. And there is divided options from colleagues around the world. There's many people who use coaxial, bimanual. We're gonna demonstrate both of them. But right now we're gonna ask our audience about, with the first survey, about what do you guys think? And we wanna know your experience. It's gonna be very important. There you can see all the questions, how many cataracts you have done, how confident you are in doing irrigation aspiration, to rate irrigation aspiration in your option. These are very important things for us to understand, the level of your training and what can go correct today. I want to take one moment to say hi to both of really, really good friends, Atanas and Dimitro. They're colleagues from far, far away. There's Slate out there, and they're still, in the computer trying to learn from us. It's such an amazing experience to be connected. So right now we're gonna see the results, please, of what's going on. And we're gonna go to live surgery here, and we're gonna start demonstrating. Okay, so we have a very mixed audience, very interesting. People with, it's almost a 20% for everybody, right? 20% with a lot of experience and people starting. However, maybe 60% will say that they are somewhat confident. And I dare you to be confident with all the mistakes I'm about to make right now, because there is a lot of risk in irrigation aspiration. Then when you ask about bimanual versus coaxial, interesting. Bimanual wins with a 52% against a 48. And, you know, but very, very interesting, Marshall. I love your questions. And it's like, okay, everybody is like somewhat confident, but they do think that it's challenging to learn it. Interesting, right, Marshall?
I would agree. You know, you have obviously some diversity in approach with hardware between bimanual, but what's interesting is a lot of people say it was somewhat difficult to learn, 42%. And then when you look at the last question, it's clear that the cognitive aspects, the manual dexterity aspect of irrigation aspiration is actually not that technical. It's making good decisions in the eye. And that has more to do with your thought process than anything. So it's very interesting that 55% of the viewers say that it's the cognitive aspect of I&A that's the most difficult.
Yes, and that takes us to the fifth question. Very interesting, and it's a 55 versus a 45% of if people think that this is, you need to master motor skills versus cognitive skills that we're going to talk about this decision making every time you're in the eye. So we're going to see the simulator now, and you guys are going to see everything that can go wrong. And there's a lot of things, so you should be aware of what could happen, okay? So let's see. Can you see the simulator? Yes. No, but okay. Lisandro, they're seeing all the screens. Can we see the big screen here with the simulator so they can see a better image of the surgery? There you go. Perfect. Excellent. So we're gonna start with. And that's one of the good things, you know. I'm asking you, what you want to start, coaxial, bimanual, and that's so important to learn, to have the capability to choose what you want. But I dare you to see everything I can do right or wrong. I'm going to start coaxial here because I really like it. Oh, okay. And, you know, I go here. Oops. I'm bringing it. That looks pretty nice. But then I go here and, oh, what happened there? Can you understand what happened there? That's another mistake, you know. The machine is telling me not to operate without the right reflex. Oh, what happened there, guys? Can you see that? Okay, nothing wrong. We can keep going. You know, and this guy doesn't like irrigation aspiration. Oh, can you see that? I'm bringing not only the capsule, but the sonula. Okay, that doesn't matter, but oh, I went up. And the endothelium is gonna remember me here. Thanks God Dr. Susan Jacobs is here with us and, you know, can do a transplant. So, you know, one of the things that we need to talk about right here is the many mistakes we can do here. What do you think about my performance, Dr. Jacobs?
Well, Ivo, I would say you are performing very well because I know you're actually a very good surgeon. So you're actually doing a beautiful job of demonstrating purposely what all can go wrong. But it was interesting how it was shown so well in the video, and some of the problems, if we go through that video again, was that when you started off, you went and caught the anterior capsule. So your probe was facing up, you caught the anterior capsule. You didn't realize that, and you kept increasing the vacuum. And when you do that, remember that the anterior capsule is attached to the zonular apparatus. You got a zonulodialysis, you got a dialysis of the entire bag, and you didn't stop at that. You should have hit reflux, you should have let go of the capsule, but you continue to aspirate and you ended up with a larger mess. What happened next was you caught the iris. In fact, actually, you caught almost everything that was there that was catchable in the eye. You caught the iris, and we saw how the iris started chafing. And one thing that you notice, if you catch the iris or the pupil during surgery, is it doesn't forgive you. So once you go and catch the iris, it has a tendency to keep coming into your port, and that's something you really have to try and avoid. Maybe you can, stay away from that quadrant if that happens once, or you can use your second instrument to kind of hold the iris away so that that doesn't keep happening. Well, after that, you got, I think the next thing that happened was a posterior capsular rent, though I cannot be sure. I don't remember the order. And that, of course, happens if your port is facing downward. So that's a very important thing when you're doing surgery. Always, always see the IA port. You should always have the IA port visible. You never rotate it down so that it faces downwards, because that's when your chances of a PCR happening is really, really high. And after that, I think you hit the endothelium. And remember, there's the descemetes there. If you catch the descemetes, I've seen cases where the entire descemetes get stripped off, and that's basically a DZEC, descemate stripping, though you don't have an endothelial keratoplasty button to replace it right there, but you can also strip the descemetes, and you can have a whole lot of issues if you're not careful while you're doing an IA.
Perfect. So let's try to do it now by manual. Let's do it like this. We can also, we have two instruments and they can get into the eye. One it's completely, one has an angle, and then you can pick which one is the best for you. Oh, that's the destroy eye. Sorry guys, let's try another one. Okay. Right here, let's see what's going from the simulator. And we're gonna do it by manual, but we can do a couple of mistakes too here. No. Here, there you go. Okay, so we're irrigating. And again, right, one of the good things here is I can have more control of the eye, but the eye can go anywhere. There's the endothelium again. And sometimes it's not easy to separate the cortex from the anterior capsule, right? And we can grab it. Can you see that? Try not to do that at home, okay? Because that's the anterior capsule and you need to differentiate it. Then sometimes, it's not, oh, there you have some. There's no easy way to go there. And that's the posterior capsule. And we are doing some mistakes too. Okay, and this is a very, very bad thing. So the important thing here is to understand and to know everything that can go wrong for us. That's very, very, very important. And I think it's a very important to build from all the mistakes that can happen. And then if you understand that, you mentally are prepared for what's coming. It's a better learning curve to learn. The slides again, please. Perfect. And then there's going to be a lot of discussion. We were talking in Spanish today about, a lot of discussion of coaxial bimanual. I think the important thing here is to think about pros and cons from any of them, okay? And you basically need to understand that in the coaxial, you can do one incision and you have more stability of the anterior chamber. The difficulty is, as you can see there, is the subincisional cortex. That's very hard. In bimanual, if you can switch hands, and here there's a key because you need a second paracentesis sometimes, is to reach the entire circumference, but you're more comfortable, okay? That could be very important for you guys when you're learning. Be always careful not to do a bimanual without a sleeve from the main incision. That could be a problem. Next one. Okay, the important thing here is to have a correct mind and body approach for a correct and effective irrigation aspiration. We ask the question, is it the motor skills who are more important, or are the decision making? Also, I think the mental aspect of this step, it's very important as well, because you can get nervous when you have a subincisional cortex that you can't reach. But then again, the cognitive part, the decision making, is going to be extremely, extremely important. As we always say here, you know, the cognitive the cognitive aspect, we would like it to call it the FICO algorithm. So we believe that we can have an algorithm for every single step. You need to be prepared to make the better decision making and problem solving. As we said, the cognitive is not about only decision making and problem solving, but a surgical judgment. You know, safety should be first at all times. This is a very important step, and is the second step that you can have a posterior capsular break, and the surgery will change completely. So this is very important too. Next one, please. Psychomotor skills, again, we're talking about manual, coaxial, and it's very important to deconstruct all these tasks. We're gonna go and deconstruct these tasks very specifically. It's gonna be very important too. And we're gonna deconstruct that in these 6 important areas. We're gonna have a correct technique. We're gonna talk about parameters and fluidics, because they have a very important role here. Hand position and hand movements are gonna be extremely important as well. You need to visualize and synchronize everything that's happened. And you need to have this mental map of the cortex in 3D. So if you really think about it, INA is very hard actually, because you are synchronizing so many different aspects. So imagine what is for your brain, you know, to put all these pieces together. But we have, you know, good tools to learn it faster. Dr. Jacobs?
Yeah, that's a nice slide, Ivo, because I think it very aptly summarizes your transition from a beginner surgeon to a more experienced surgeon. When you're beginning, remember that it's always safety first. You might have seen a large number of IAs happening with great ease, but remember your first priority is safety, and for that you have to go slow. You have to take look at each and every thing. You might have to see which port you're using. Is your port always facing up? You would have to see if your irrigation ports are perpendicular to the aspiration port, because you want the fluid flowing out to the side. So you have to adjust that. You have to adjust the length that the tip is exposed, because the person, your assistant who's passing it to you, may not have fixed it right. So if there's too much of a tip exposed, you might have fluid coming out of the chamber rather than into the chamber, and that could lead to AC collapse. So there are a lot of things safety wise which you need to go through first, and then as you build up your confidence with IA, you can go on to increasing your speed, and you'll realize that this really becomes a very pleasurable part of your surgery. There are a lot of decision making, as Ivo already said. You have to decide whether you're going to take your subincisional cortex out first, or are you going to leave that for the last. How are you going to manage if there's a little bit of zonular instability that you see. So there are also a lot of decision making things that come in, but remember, when you start out, it's always safety first. Look at each and everything in your setup, look at the machine parameters, and then carry on. Okay, so the next thing is that you have to always look at the fluidics, as we just mentioned, and it's important to know what you're going to do, what are the kind of parameters that you're going to use for each step. So basically, it depends on whether you're removing epinucleus, when I say cortex aspiration, I'll also refer to epinucleus, or whether you're removing cortex, or whether you're just doing some capsule vacuum. So a good bottle height is always important, about 100 centimeters, and that's because you want your chamber stability to be maintained. Depending on what you're going to be doing, you could vary the flow rate. You could have a higher flow rate if you're removing the epinucleus, or if you're removing OVD at the end. If for cortex, you could bring it down just a little bit and go slightly slower, depending on when you're starting out. If you're really a starter surgeon, you could go as low as 100 mercury, but if you're reasonably confident, you could step it up to 300 or 400, or in the better machines, the newer machines like the Alcon Centurion, you could go up to 600, 650, because they give you excellent chamber stability and very, very little surge. If you're doing, on the other hand, cap vac, remember capsule polishing, you have to keep it at very low vacuum and very low flow rate. So it's about 5 and 5 or 10 and 10, and that keeps the posterior capsule safe, and also the anti-capsule if you're just doing some polishing under the anti-capsule. So you have to know your fluidic parameters well before you start your IA.
Yes. One of the funny stories of the day is we were talking in Spanish with a colleague that does surgery temporarily. Marshall, it's used to this, but I'm not. And when we're talking about hand position, it's funny how everything changes, right? Dr. Jacob, you operate temporally or from the forehead of the patient?
Well, I sometimes use the pre-existing astigmatism to decide where I'm going to be sitting, but I do mostly superiorly, I would say, and I do shift temporally also. Of course, temporal is the more ideal position to do because your incision is further from the visual axis, and so you're going to have less astigmatism. But ergonomics-wise, you don't have that forehead to rest your, hands on. So it may sometimes be more difficult to rest your fingers on, rather, I'll say, not your hands on, to just the tips of your fingers on. So I'm sure, Ivo, you're going to be talking more about that.
Exactly. No, and that was specifically my point. I'm used to do surgery from the forehead of the patient, and like hand position will change completely. But the important thing here is to float through that incision. The eye needs to be centered at all times, and you should be floating. As you can see this in this lateral view, there is also a movement of rotation you can do with the irrigation aspiration piece that will allow you to rotate and achieve the 360 degrees of the circumferences. This is very important, and you just can't press down or up that incision. Also, an important thing here, Dr. Jacobs, for you?
Yeah, it's always, you just mentioned it, Ivo. You have to be very careful that you're seeing the anterior capsular rhexis edge all the time. And for this, there are a lot of things that you can do. Position the patient the right way. Make sure that his iris is perpendicular to the ground. The chin should be a little lifted up, so you're having a very good red reflex. You should make sure that you're on coaxial lighting once you've removed the bulk of the epinucleus, because then you can see the wisps of cortex very well illuminated with the coaxial light. And you should also, if you're a starter, you could also use trypan blue to kind of mark the capsule or stain the capsule, and that gives you an idea of where the capsule is. But you always have to be aware of this and keep looking at the capsule, because the capsule can confuse sometimes with the cortical matter. But if you really look at it, you can differentiate them. It's not too difficult. The cortex is more wispy and it's got strands. It doesn't have a smooth, continuous curvilinear edge that we are so used to seeing with the rhexis. The rhexis, we know, is a continuous curvilinear capsular rhexis, so it's always circular, it's always smooth, it's always even. And the important thing is the rhexis, the anticapsule, has the sheen or that glistening appearance, which makes it kind of a specular reflex, which with which you can very easily differentiate that and the cortex. And also you have to have an idea of the three-dimensionality to also be able to distinguish between cortex and the anterior capsule. Ivo?
Yes. Here it's very important for us to understand and differentiate. As you can see that I did a big mistake I didn't differentiate correctly the cortex from the anterior capsule. You need to be, as Susan Jacobs was saying, very aware of what the limit of the anterior capsule is. That's tip number 5. Tip number 6 for you, Dr. Jacobs.
Yeah, very nice tip, because this is something that I also just passingly mentioned earlier, that you should always see your aspiration port. You should always have it facing up. You never face it down. So even when you're introducing the tip into the chamber, be careful that you're having the aspiration port up. You can also have it face to the sides if you're especially if you're trying to get out that subincisional cortex, you can turn it a little bit and then rotate it to grab that subincisional and rotate it, but never face it downwards. Because when you go downwards is when you can have a sudden surge, or you can have any sudden chamber instability, or you might yourself go a little bit too posteriorly and catch the posterior capsule, and that leads on to the disastrous consequence of a posterior capsular end. So that's something you want to avoid. So make sure you're always seeing the port.
The other one? Last tip,
so I think that's another important thing that you also have to know, and that is the difference between stripping and sucking, or stripping also called, you can also call it as peeling. And that's really very important when you're handling cortex, because you don't want to just when you're doing IA, you actually go beneath the you have to have this three-dimensional perception. You're below the iris, you're below the anterior capsule, and you go and grasp this cortex, and you make sure you've got occlusion of the port, because without that, you're not going to be able to pull it to the center. Once you've got occlusion, you start increasing your vacuum a little bit, and at the same time, you move your hand or your tip to the center of the the pupil, so that you're actually stripping. You want to strip the entire cortical sheet to the center of the pupil, and that's when you press down more on the foot pedal, so that you're actually aspirating that cortex away. So you don't want to aspirate right when you're near the anterior capsular edge, because what can happen then is that bit of cortex can come out and you lose the hold of the cortex, and then the anterior capsular part may come off, but the posterior capsule will still remain there, resulting in difficulties later. So always remain, capture, always remember, capture the, get occlusion, peel towards the center, and then increase your vacuum, so that you're actually stripping and then aspirating.
Perfect. So let's go to the simulator. I think the simulator is an amazing tool to teach irrigation aspiration in many, many levels, especially from the starts, from the hand positioning we were discussing. Right here, you have a temporal, incision. I'm forcing myself to do an incision that I'm not used to. I need to change a little bit my hand position, but we can do that. And I think that's the power of simulation. I can pick to do bimanual or coaxial with different settings. I'm going to tell you. And then it's very important that I have my own phaco machine right here in the script. Okay, I have an irrigation with a height bottle, aspiration, flow, and I can manage all my settings. We're going to discuss that because it's a very important question all the time. So I'm going to get into the eye now. With first of all, and the important thing I need to set, which is going to be the irrigator and the aspirator. And we're going to start irrigating here. We enter the eye in position 1. That was one of the mistakes I did. As you can see there, I can have a very, very nice anterior chamber. And then I'm going to put as you can see, I'm struggling with the hand position, but I have a centered eye. Okay. You can see the lateral movements. You can see the whole, it's always looking at me, because I don't want to be risky and to get the posterior capsule. And there is two very important things here. I'm going to go very slow to deconstruct this tasking, going for the cortex, hold it in position 2, bring it to the center, as Dr. Jacob was saying, and strip it, carefully to the center. And then this is synchronization, okay? I grab it, I know I have it, and I'm going to take it to the center right here, okay? Very, very nice and easy. Dr. Ike Ahmed, a couple of weeks ago, was telling that he likes the job to be done from the fluidics. So he doesn't like to go to the center and aspirate cortex right there. But then again, the important thing here is if you have the correct principles of irrigation aspiration, you can do any of them, and it's very easy. One of the good things about a bimanual thing is all that cortex, it's not easy to reach. Look at, it's not easy to reach here or like this. You can do it, but then, remember the principle, safety first, and you want a good go. So you go to position 1, you remove the aspirator, you remove the irrigator, and you switch hands. Okay, it's as simple as that. And there you have more safety for your heart and the patient. And then, look at how easy it is to get that subincisional cortex. Take it to the center and, rise the vacuum, or, you can go here and let the vacuum do the job. There's two different options here. Okay, and there's a little thing here floating. I take it to the center and then I go, okay? So this is a bimanual technique. Then we can do a coaxial one, but then again, I think the important thing here is to understand that the principles are the same. There is pros, there is cons, but the principles of irrigation aspiration are the same. And since we were talking from the beginning, you can have in the machine a coaxial from like straight 45 degrees, 90 degrees.
Ivo, if I can just make a point here.
Yes, of course.
Of course, when you were using, and for the benefit of the audience, when you're using a bimanual IA, you would have your main port. If you're a right-handed surgeon, you would have your main port there, and that incision would already be large. So you probably would prefer either putting the irrigation using the coaxial probe, maintaining irrigation using the coaxial probe, which has a soft silicone sleeve around it, which plugs the wound and doesn't let fluid come out and lead to AC collapse, and then use the side port for aspiration. Or if you're not using your IA, coaxial IA for irrigation, then you would make a separate side port, a small incision, because you don't want to use a large incision. You'd use a separate small incision, which would ideally be 180 degrees away, but you could also vary depending on where your nose position is so that you're not impeded by the nose. And you would use that for your irrigation so that you have a stable chamber. The other beautiful thing that you showed, the beautiful thing that you showed, Ivo, was also how you were actually rotating that probe. So you were going and, you were holding, when you were going subincisionally, you were rotating that port so that you were grasping the cortex, and then you were again rotating it outwards. So this rotation movement is really useful for stripping, as we were talking about stripping earlier. And I think you just demonstrated that beautifully as well. So I think that was really a very good demonstration. Are we having more demonstrations, or is there?
Yes. Let's do one, a coaxial one. With the same things. And I agree 100% with you, Doctor. We had the same discussion with the last colleague. And I think, there are very interesting tips and principles that you can adapt. Then always remember to get into in position 1, okay, guys? Because here, if you don't have, a high bottle and completely form anterior chamber, you can have problems. And then you can go with the center eye. As you can see, it's a little bit more difficult. I don't know if I put level 3 or level 4 here, because, as you can see, I'm making decisions all the time on how is the sonula behaving, okay? When I'm stripping, I'm always looking at how the capsule is behaving, if I'm not also bringing, some of the capsule with me because of the sonula, right? But then again, this is very important, all right? The first thing is I go for the cortex, I occlude the tip, and when I have occluded, I take it to the center and I start rising my vacuum with the pedal, and it's very safety. It's very safe, and the sonula is not suffering. Since I have a 40 degrees, it's easier to reach, the subincisional cortex. And then again, I go slowly because I can see there that the sonula, it's suffering to it, it's coming with me. The machine is telling me not to operate without a rod reflex. That's one of the most important things of the machine, and I love it. It's forcing me to have a centered eye. And here in the safety zone is where I do, the vacuum, position 1, and I go out. And what about also the parameters, Dr. Susan?
Yeah, as we mentioned earlier, the parameters would depend also partly on whether you're a beginner surgeon or you're a more experienced surgeon. So when you're beginning, if you're a beginner, it would preferably be ideal to keep lower settings. You can start with lower vacuum, and as you become more and more experienced, you can increase your vacuum. The bottle height would generally be around 100. The flow rate would be around maybe 40 or 50. 40, I would say, probably. And depending on what step you're doing. The other thing that you showed again very well was how you were occluding the port before you were stripping or aspirating Evo, and that's another thing I think everyone who's doing IA needs to understand. If you don't have full occlusion of the port, there's no point of moving the probe towards the center of the pupil, because then the cortex is not going to follow it. And you can actually get that occlusion of the port by either going a little more under the anterior capsule, that means into the fornix, or you can get it by going sideways. So you can also have a sideways sweep, which grabs more amount of cortex into the port, occludes that port, and then you can start stripping again. So I think you've got a thing of the settings there, Evo, and would you like to go with peristaltic machine? I see, of course, it gives
you. The good thing about the simulator is we can have all the settings we want, and actually you can change your setting and see how the machine behaves. But what we recommend is when we talk about irrigation, a height, the bottle height to be 100, maybe a little more, 105. Sometimes I like a very, a posterior capsule right far away from me. Vacuum needs to be decent, 300, 350 millimeters. It's something good. I mean, you can rise it or put it a little bit down depending of the characteristics of the cortex. Flow can be in 25 to 30. Then again, all these parameters will change depending how, not only about the cortex, but about how the eye is behaving, okay? This is completely dynamic, and you should be very knowledgeable of this and adapt to every situation. Also, another yes, sorry.
The other thing also is that that this is under surgeon linear control. So even if you set 300 there, you need not press down all the way on the pedal. So when you're actually grasping that cortex first, you're not stepped fully down. You're just a little bit part of the way down. So you're not at 300 or whatever you're selecting. And then as you come towards the center is when you put your foot pedal further down and harness that entire vacuum. And of course, the parameters, as Evo already said, would also depend on machine to machine variation. So there are some machines, the newer machines especially, which have tremendous chamber stability, and there you can use much higher vacuums. And the older machines, generally you use lower level of vacuum.
That's a very important concept, right? Because you can have your settings, but the one who's doing the job is the foot in the pedal, and then you're, as we were saying, you're constantly doing decision making and adapting and listening to the machine. Very, very important. I agree 100%. One of the other good things about the machine in this case is that it will give us feedback, objective feedback of what happened and why it happened, okay? So it's gonna talk about efficiency, about how we did handle the instruments. In this case, if it's the instrument, it's horizontal or non-horizontal when you put it in. If you're in position 1 when you're entering the anterior chamber. How about the tissue treatment? There's many structures that you can hurt in this case. You can have an injured cornea, and then you can have a contact with the iris, anterior chamber collapse. There's many things that you need to in irrigation aspiration. And then of course the target achievement, and if you remove the entire cortex from the bag. Let's go then to the slides, and in the time lapse here, since we're changing, in a time lapse the machine will show you what happened, in which moment it happened, and why did it happen. It's very, very important to understand. Okay, so right here, and this is an amazing concept that Marshall really likes too. It's about this 3D concept of the cortex and how the cortex is its position in the bag. And sometimes they tell us, okay, go for the cortex, position 2, you occlude and you bring it to the safety zone. But if we really understand the 3D disposition, we understand that the stripping is very, very safe. Also, always understand, and we said it many times, that the subincisional cortex is the one who's going to be more challenging. So in those moments, you can be more mentally prepared. As I was saying, okay, especially if it's coaxial. When it's bimanual, you saw it like 2 minutes ago, that you can switch hands and you can go to the subincisional cortex. Dr. Jacobs?
Yeah. I think that was a good point about subincisional cortex. The other things that, before I go to this slide, just something that I'd like to add to the previous slide is that you also, certain tricks to get rid of the, are you going to be talking about that later, Ivo? I don't think so, right? Subincisional cortex? Are you going to be talking about it more in later in detail later?
Yes, we can talk a little more, but go ahead, please.
Okay. All right. So some of the things that you can do when you're a beginner, especially, is remember that it's subincisional. So the angle that you're going to access it is more difficult. So it might help in your initial cases to kind of have the rhexis a little larger, or at least don't make it short under the incision, because the shorter the rhexis is, the more difficulty you're going to be having to get rid of that subincision cortex. And of course, you've already mentioned most of the other things, like you can use special tips. You can also use CapVac, which is a good mode to try and get rid of that subincisional cortex. We use it a lot in our hospital. I don't know whether other people are also using it, but CapVac is a very safe mode where you can, instead of being in a normal IA where you can suddenly get a PCR, you go on CapVac, so you know you're at very, very low vacuums, and you pick up that those last wisps of cortex and aspirate them to the center. Of course, the last resort, which you should also know about, is the simple Simcoe, the Simcoe cannula, which you can also use even if you don't have a bimanual, and you could use that as well for removing the subincisional cortex. Now, about this slide, I think most of it is already mentioned. The hand position Ivo mentioned about, foot pedal position is important. One, when you're entering, and then two, and going deeper and deeper as you're increasing the vacuum. AC anatomy is very important. So that's basically knowing the three-dimensionality. You should know that there's an iris there. And I see many times people go below the iris, and you need to know that there's a distance from the iris to the anterior capsule, and then from the anterior capsule to the cortex is a little bit more distal gap. So you have to be under the anterior capsule. If you're just below the iris, you're not going to be able to grasp onto that cortex, and instead you'll be only grasping the iris. So that's important. And then I think the other things, I cannot read what's written in blue. IA movements and parameters. Okay, parameters we already mentioned. The other thing, Ivo, I would probably like to say at this point, I don't know whether you had a separate epinucleus session, but I also like to include epinucleus under cortex, because that's also something you have to get rid of. And the settings for epinucleus is higher. That's where you put it at 650 and you go under it, because that's thicker. You need much more vacuum to go it. So you can press your foot pedal all the way down with your port under the epinucleus. So the best way to get rid of epinucleus is, kind of loose, and sometimes it gets loose on its own, and you're nice and happy about it. You can remove it with your phaco tip immediately. But if you're trying to remove it with your IA tip, remember a nice way to do it is kind of loosen the cortex on all sides. You grasp and pull, grasp and pull, grasp and pull. And as you loosen the cortex on all sides, the epinuclear shell also loosens automatically, and you get this epinuclear shell to start moving around. And then you can remove it, and you can keep your IA port below the epinucleus and push your foot pedal all the way down to 650, and then you can use that entire vacuum which you had programmed to get rid of the epinucleus. And then when you come back to cortex next, then you can use those lower levels of vacuum. All right. So the next slide is about knowing about where your foot pedal, where your reflex button is. I think that's crucial, because this is somewhere where it needs to come as a second action, as a reflex. Actually, you should be able to do it as a reflex. The minute you see that spider web reflex, you have to hit your foot on the reflex button, because if you don't do that, you might end up getting a PCR. Remember, at the same time, when you see that spider reflex, not to withdraw your hand backwards, not to pull back suddenly, because then that's again going to cause so stay steady, stay right where you are, and hit the reflex button, and always know where the reflex button is in your foot pedal, generally to the left hand side. You just swing your leg and hit that reflex button. Sometimes it could be programmed to be elsewhere. So before you start the surgery, find out where it is, and then hit that reflex button and get rid of that grasp that you've suddenly got on the posterior capsule.
Very, very interesting. And I have an amazing story of a colleague that when he was teaching, he will ask all the residents where the reflux is, what the function is. If the resident didn't know where it was, it will remove him from the surgery and will not teach him, because reflux can save your life, right? And it's a very, very important function. We're gonna do it now, and there's so many residents when they are starting, they don't know what it is. So I'm gonna go again. I'm gonna try to do a coaxial and a bimanual one, and this is the moment for everybody to ask questions in the chat, in the Q&A. We're gonna be, waiting for them, and then we're gonna answer. But again, I need to, and we need to talk about the synchronization that is happening here. Okay, you need to understand I'm with the correct ergonomics, correct hand positions, moving through that incision with a centered eye, not pushing, not taking it to the sides. It's completely an hermetic anterior chamber, and also understanding perfectly the physics and the disposition of the cortex in that bag. Of course, you said it in the beginning, the decision-making process at all times. I'm doing something. How it's behaving, how the capsule is behaving, how the sonula is behaving. And then I would need to adapt, not only what I'm doing, but also in the parameters, okay? So let's try to do another irrigation aspiration here, okay? And let's start with coaxial, and let's start with the one that is straight, and this is harder to move in the anterior chamber, as you can see, and it's not easy to go to the subincisional cortex, but you can rotate the probe, okay? So let's go again. We understand the 3D disposition. We go right below the anterior capsule. We have it. I know I have it right here with me, and I will go slowly to the center and, and do more vacuum. Here again, the same thing. Sometimes we can do side movements, and you can separate that cortex that it's completely connected, and you can disconnect it like to the sides, as you can see. Look at there, okay? And you're not tractioning the sonula that much. And you have a little fragment, you take it to the center. Then remember that there's different ways to do it, but the principles are always the same, okay? Let's do what we were saying about the reflux. I go here, and by mistake, I have the posterior capsule. Oh, and you can see right there, if you see the parameters in the top, I'm gonna grab it again. Okay, and in the parameters below, you can see that the vacuum, it's negative, and the flow too. Okay, I have it. Reflux. Always know where the reflux is. But I did a posterior capsular break. No, I don't know. Yeah, I did a little. It was very, very small. But then again, with a coaxial one, you can reach the subincisional cortex. Okay, you can do it. But the thing is, what are the principles? Isn't it safety the most important thing in this step? What do you think, Dr. Jacobs?
Absolutely. I think that's very well said, Ivo. You have to get all your principles right. Make sure everything is good. And also remember that even IA, as every other step of phacoemulsification, everything, the success of every successive step of or succeeding step of phacoemulsification depends on how well you've done the previous step. So remember, just as part of the safety, your wounds are as crucial. You don't want to have leaking wounds. You don't want to have wounds from where iris is prolapsing. Your hydrodissection is crucial. So it's very, very crucial that for a good cortex cleanup, you had done a good cortical cleaving hydrodissection, because there are additions. Especially, you also need to be aware of the anatomy of the cortex, the difference between the epinucleus and the cortex. The reason I keep bringing up epinucleus again and again is in our hospital, many of us remove, when it's completely loose and floating, we remove the epinucleus with the phaco probe, but otherwise we use the IA probe for removing epinucleus. You need to know the differences between the epinucleus and the cortex and the way they behave. Epinucleus kind of breaks off in chunks if you aspirate it, whereas the cortex is more the strippy fibrous material that you can pull better, whereas you can't pull on the epinucleus as much. Also, you need to know that there are attachments between the capsule and the cortex, and these are more firm on the anterior capsule and in the fornices, and the posterior capsular attachments of the cortex are not as strong. That's the reason you have to tug a little bit more when you're in the anterior capsule and the fornicial part of the cortex. So all these things, this knowledge, this awareness, and your phaco-dynamics, phaco-fluidics, all these things are really important in being able to do a good IA. Remember also the difference between using silicone sleeves and metal sleeves. Metal sleeves, I don't think many people use at all now, but previously it was it was quite commonly used. And remember that the metal does not plug the wound as well. So you can have a lot of leakage around metal sleeves. Silicone sleeves are obviously better because the leakage is less. I think that's probably some of the other things that I wanted to put in there, Ivo.
Yes, yes. No, I would love you to comment this video. You know, it has so many concepts that you were talking about.
Okay, just let me zoom it up 1 second. Yeah. Sorry.
You want to start it again?
Yeah.
Start it again, please.
Okay. So yeah, I think so you can see that there's a good wound position here. You've got a second instrument there, and you can see that how the probe is actually swiveling. So you can see there are lots of motions that are involved in the probe. You have swiveling motions, you have rotational movements, you have pulling movements. You have so many movements which you can combine to get good, aspiration of the cortex safely. Anything else you want to add, Ivo, there?
No, you know, we love this side, this lateral view of the, because sometimes we are used to see YouTube videos, and in this view, you specifically understand that all the movements of the rotation, specifically, you're doing to reach different parts of the back, right? We talked about the hand position today. I think it's very important, right, Dr. Jacobs?
Absolutely. The way you rest your hands is important. The distance between your two, your main port and your side port is important. Everything absolutely gives a lot of difference. I like to keep the gap between my main and side port as wider than what you've kept here. But of course, there's a lot of individual variation in what you prefer. When you keep it a little wider apart, you have access better access all around. And also the other advantages, it's sometimes easier to hold the eye completely coaxial, in the position you want to. So ergonomics is of course important, and not only ergonomics as relates to your hand in relation to the head of the patient, but also your entire ergonomics as a surgeon. You want to be healthy for your whole life. So it looking slightly down, not leaning forwards, having the patient pulled up close towards you, chin up a bit, good coaxial reflex. All of these actually count a lot. Especially the coaxial reflex. You don't want to be pushing down on the eye, because that's when you kind of lose, when the eye rotates downwards. And that was what Ivo was also saying. The machine kept prompting him to keep the eye in the right position. So you don't want to either push the eye downwards or inferiorly, so that you lose the red reflex and then you're not being able to see well either. Other thing I would probably also tell here is that if you're using very high irrigation and you've been operating for very long, sometimes you can get corneal edema. So make sure your visualization is good. If your incision has sometimes cut slightly into the conjunctiva, you can get ballooning of the conjunctiva, and you get all this pooling of fluid over there, which can interfere a lot with the reflection. So make sure your incision is good in that aspect as well. And also, if that happens, make sure you get rid of all that pooling by just making a small nick and squeezing all that fluid out. So keep your visualization at a very good level always, so that you always see the cortex well, and you're able to see what you're doing well. Don't guess and do. That's something that's really crucial.
Okay, and we tend to go over and over again in many principles, and I think that's the key in irrigation aspiration, to understand everything that happens from the hand position, incision, what's happening in the anterior chamber, correct parameters, identifying the high risk zones. And if you understand everything and everything that's happening in the anterior chamber and how to reason in an anterior chamber, you will master any coaxial, bimanual, in different cases, high myope eye. So I think we did a job of repetition, and this is one of my favorite videos, because it shows you a new perspective of what irrigation aspiration is. You saw me do, you know, an irrigation aspiration with a coaxial, and it was that one. This is a simulation scene reconstructed and seen in this amazing view. And I would like you to really, really pay attention specifically on how the capsule behaves. You know, when the fluidics change, you can see how not only the capsule, but the sonula will react to all the movements on all the, you know, the vacuum and the flow rate you're using. So this kind of video, I think, are very important in your cognitive training to understand what's going on in the anterior capsule. If you understand this, then it's going to be very, very easy for you, you know, to start slowly, to start with the principle of safety first. And, you know, I'm sure there's going to be many questions about parameters, about should I start with bimanual, coaxial, but I think in this hour we did a good job on about for you to understand all these surgical principles that are going to be so important for you. You know, here, for example, we are in the subincisional part, you know, and it's, I mean, you can see an expert surgeon doing this very, very fast. But the key here is there is many, many elements involved. If you understand everything that is involved, how he's rotating, how he's always looking, he knows where the hole of the back, you know, of the irrigation aspiration tip is. And at all times, he needs to have control of what's happening and react to how the bag is behaving, right? I think this is very important. And, you know, with this last concept, I would like to end here and start, you know, questions so we can answer, because I'm sure there is many, many interesting questions. Marshall.
All right, so great discussion, guys. Thank you for the live surgery in both modalities. There are a number of really great questions. So my good friend from Argentina wants to know, Mariana asks, what are the relative advantages, in your opinions, of a Venturi pump versus a peristaltic pump when doing irrigation aspiration?
Dr. Jacobs, you want to take that one?
Yeah, sure. So we all know that Venturi pumps are faster machines. You know, sometimes you may have a little less control, especially if you're a beginner surgeon. So vacuum is always on, whereas in peristaltic, the vacuum starts to build up only when you get occlusion. And many of the newer machines are peristaltic. They work extremely well. You have a higher degree of kind of safety when you work with the peristaltic machines. They're said to be slower, but as I said, the newer machines are quite fast. Previously, you know, people used to also like Venturi because it was faster, and when you work on a peristaltic, you would feel that things are going too slow. The newer, I think the problem is no longer there, and they work very well, while at the same time giving you that measure of stability, because vacuum starts to build up only with occlusion. So I think peristaltic is quite a good option. Of course, if you're a Venturi surgeon, you could still do that as well.
Yeah, modern fluidics.
Sorry.
I mean, anybody who is in the operating room in the early 2000s can tell you fluidics have come a long way in the last decade, that's for sure. Here's a wonderful question with a slight added complication in cataract surgery. How would you recommend managing cortex when your patient has a small pupil?
That's a very good one. That's a very good one. And I think, well, first, I think you need to be an expert, because, you know, here is to understand what is going to happen, not what is happening. You need to have this mental image of the bag and how the cortex is specifically placed, so you can do it. I think it's high risk, because we're talking about all the time about safety first, right? In these cases, sometimes you're not putting safety first, so you need to slow down, in my opinion. You know, the mental part, you need to slow down. You need to make decisions very carefully, and you can do it. But then, you know, you're always, you know, putting safety not as important as it should be.
Yeah, I think the other thing that helps you when you're doing cortex aspiration in small pupils is you can still see those wisps of cortex, small wisps that just protrude slightly beyond the pupillary edge. And you can go direct yourself towards those. And also you need to know that you're not going to be going at the pupil, at the iris, but slightly below. So you have to have that three-dimensional depth assessment of which level you have to go in to be able to grasp that cortex. You have to go slower, so you're not seeing, so you want to be sure what you're aspirating, so go slower, and then start to aspirate. And then, of course, as someone just put in the chat, you could use a dilator, an intraoperative dilator. And of course, if you still don't see, you have a variety of pupil dilating devices. The other thing that you could do, even if you don't want to put the pupil dilating, is use a rod or something like that in your left hand to just try to push that pupil aside a little bit. Putting viscoelastic repeatedly inside also helps to dilate it temporarily, and then you can get an idea of where the cortex is going there and aspirate before all the visco goes out. And pupil dilators, of course, are always available, and they're wonderful ones to use. You have the Bhattacharjee ring, you have so many other, the Malusian ring, you have iris hooks. There's a variety of ones that you can use.
Here's a nice question in terms of selection of tips in a coaxial mode. May Louisa asked, is it absolutely necessary to use a bent tip to attack the subincisional cortex, or can you work with a straight tip?
Again, yes. If you're experienced, you can do it. Sorry, Susan. If you're experienced, you can do it. You can reach it. You can always play with the position of the eye, and you can reach it. Then again, always for people who are learning, safety versus speed versus, I can do it, but what is the best in this case? But yes, there is many surgeons that can do it with a straight tip. Sorry, Susan, you were saying.
I use a straight tip. And I use coaxial. I don't use bimanual much just because we have to ask for it, and that takes a little time for it to come. So I just continue with the coaxial. But remember, that's not what I would advise you to do when you're a beginner. If you prefer bimanual, please go ahead and use that. You can always do it with a straight tip also, except that you need to kind of rotate the tip a little bit posteriorly so that you're grasping that thing. Go again slower. Don't go at high speeds, and then pull, aspirate, pull, aspirate. And remember that you have to get that occlusion of the cortex before you aspirate. It's going to be a slightly more difficult angle of approach. Remember that sometimes you're working more vertically, and you can also at the same time cause a striae or folds to appear in the cornea, so your visualization may not be as good. So you have to make sure, again, the red reflex is good. You could ask your assistant to put some viscoelastic over the cornea again to just get your visualization to be better. And the other thing that you can do is you can do this arc-like stripping. So you go there posteriorly, and then you kind of rotate. It's not just pulling towards the center, but it's also a rotating movement. So you're gone like that, you caught it, and then you rotate the tip also, so that your cortex is actually getting, wound over the tip, and then you are also pulling it at the same time. So a lot of things help you even if you're using a straight tip. But be careful when you're working so close to the wound, because you may have a tendency to come out, and your irrigation ports may accidentally come out of the wound, leading to a sudden chamber collapse. So that's something you have to keep an eye on always. Your irrigation ports still need to be within the chamber. You don't want to have an accidental shallow AC or a chamber collapse.
Turkai asks a very good question. In the event of a PC rupture, and you still have to remove cortex, would you revert to a manual IA cannula, or would you opt to finish the INA using the vitrectomy handpiece?
Yeah, I saw that one. That's a very good question. And we could talk about it for 2 or 3 hours. We could do a class about that. And we will actually. We will talk about a lot about anterior vitrectomy. Very, very good questions. And of course, the answer will say it will depend in many, many other factors. Okay, if you have vitreous or not, if everything is in place. But one of the good things about the anterior vitrector is exactly what you're saying. You can change the IA, irrigation aspiration cut vitrectomy. You can switch it, and then you can use the vitrector to go for the cortex. I normally do that. I prefer to do that with the vitrector. I don't like to put, again, the bimanual, but then again, there's other colleagues that can think different. I don't know what you do in those situations, Susan.
Again, as you said very rightly, Evo, it all depends on whether you have vitreous prolapse or not. So you would want to stain with triamcinolone, preservative-free triamcinolone, and see if you have that in the first place. And then your further management from there onwards would depend on a host of other things. How big is the PCR? Is it possible to do a vitrectomy and then convert it into a small posterior capsular rhexis? Is it too large to do that? How much of cortex you have left behind? Would you prefer a pars plana approach to get rid of the vitreous, the prolapsing vitreous and the cortex, prolapsing vitreous, as versus a limbal approach? So there are lots of things. Of course, the pars plana approach is thought to be better now because you're pulling the vitreous back as well into the vitreous cavity instead of letting it prolapse more and more. So it would depend on all this. One thing that you can also do, which I don't do much personally, is dry aspiration of the cortex. So you could just take a small syringe and cannula and just kind of aspirate it, but always be careful that you're not aspirating vitreous because it's very easy to be tricked. Vitreous is transparent and you might think so. You look for those telltale signs of iris movement, the pupil getting peaked. All these things are there, and of course IVT is a great friend in these situations. You can stain the vitreous all the time and keep seeing that. Yeah, you can use a vitrectomy probe and change switch modes. That's a very convenient way of aspirating vitreous. And at the same time, whenever you see the vitreous getting caught, the cortex not coming out easily enough, you know that there's vitreous there, so you don't have to change the instruments again. With the same instrument, you can cut off the vitreous that's there and then again proceed with aspiration of the cortex.
Perfect.
Yeah.
Very
of course,
interesting.
you will not use a vitrectomy to the main port. That's crucial because then you will have fluid instability and chamber instability. So that's very crucial.
Good. There's a nice question on teaching from Atlantis. So when you're teaching cataract surgery, at what time would you introduce the teaching irrigation aspiration to a new surgeon? Is that later in training or earlier in training?
That's a very good question. A very good question. And what I like to answer about this is the different steps are completely different skills, right? Capsular rhexis is most a manual skill, a motor skill. And in this case, I will not say a rush to do irrigation aspiration, because here you need to synchronize, right? It's risky. You don't have the nucleus in the bag. And if you put in position 0, you can damage structures. So I will teach irrigation aspiration to somebody who understands the pedal, position 1, position 2, is comfortable using the machine. I will respect irrigation aspiration. I mean, probably other people will say, no, just go for INA. There's no risk there. I will respect it.
I agree completely, Ivo. I agree to that. It seems deceptively easy, but it's equally easy to get into trouble during IA. So that's something that you want to start doing after you've built up your skill levels to a little bit further down the road.
And the last question is from Miguel. So if you have vitreous during your INA and it's impeding your red reflex and your overall view of the posterior chamber, do you have any recommendations on improving the view?
Yeah, that's a very good one. And sometimes it's very hard to see. You can have different problems in the vitreous that the visualization will not be the best one. There is many cool tips about visualization with different kinds of light. Most of us, we don't have it. I will say that then again, to relax, to take your time, and to try to to see everything correctly and understand mentally that map that you have from the bag and how the cortex behaves. But it's not easy to see when you have a vitreous hemorrhage.
Yeah, I think I agree with that. I completely agree with that. There's also another question here about management of zonular weakness.
Yes, for you, Dr.
Yeah, I think that's also a good question because it basically, just to widen that question a little bit more, cortex aspiration in complex situations, it could include subluxated cataracts, posterior polar cataracts, high myopic eyes, vitrectomized eyes, all these things. You would want to modify your IA techniques a little bit. So if it's a subluxated cataract, you don't pull straight into the center of the pupil as we were teaching all along. Rather, you pull tangentially. So you want to have a tangential pull. That's because if you're going to pull straight in, you're causing more zonular stress. You could actually end up increasing that area of zonular dialysis. So you want to pull more tangentially. And of course, depending on the amount of zonular dialysis, you would decide whether you want to also additionally put in a capsular tension ring or some form of scleral support and so on. Similarly, when you have there are other conditions where you can have lag zonules, and you want to be aware about that. You want to always keep an eye, as Ivo also mentioned when he was showing his live demonstration, on the zonular apparatus as well. That includes conditions where like high myopia, where the zonules could be a little weak, pseudo exfoliation. You could also have a lax posterior capsule at the same time in conditions like high myopia, a vitrectomized eye. So all these are, and you could have a rent that's just waiting to happen if it's a postiopolar cataract. So obviously you're much more careful in a postiopolar cataract. You never do a cap back, even if there's a little bit of, a plaque left behind. You leave that for a later YAG. You don't touch that area. So these are things that are modifications of your normal IA technique in more complex situations. White cataracts, they're again known to have loose capsules which can easily go in for rent. So all these things, be careful. White cataracts, of course, there's not much cortex left, but you could, whatever little is there, you can remove often with just a cap vac, very low vacuum aspiration, and that leaves your zonula apparatus safe as well, which is also sometimes weak in these Morgagnian cataracts, hypermature cataracts.
Okay. Those would be all the questions that I flagged. So I think we're about ready to wrap up, guys.
Yes, I want to thank you very much, Dr. Susan Jacob. It's very late there, but she was so kind to be with us, sharing the amazing knowledge. Thank you so much, Susan. We had you 2 times this week. This was amazing. Thank you so much.
Thank you. Thanks so much. It was lovely being here. It's 12:45 in the early morning now, but I enjoyed every bit of it. I enjoyed it.
That's academic.
Yeah, this is a different activity, right?
It was academically stimulating, and that's something I enjoy always. Thank you so much. Thanks for this opportunity.
Thank you for joining us.
Thank you, and thank for the audience. We want to keep doing this. This is for you to keep and improve your skills during the pandemic. I think this is an amazing way to to learn and to improve your skills. This open discussion, the questions were amazing today. So let's hope to keep doing this, and we're gonna be here for you guys in the future. Okay, so talk to you soon.
Bye-bye.
Bye-bye.